Hi, welcome everyone. I'm Sania Abdullah, Assistant Director of Reunions and Leadership Giving for the Feinberg School of Medicine, and I would like to welcome you all to the major trends and opportunities in digital health webinar. Before we get started, I wanted to cover a couple of housekeeping items. I would like to ask if you would like to ask a question of us or one of the presenters after their presentation, please utilize the Q&A feature below. We have many pre-submitted questions as well, so we will do our best to answer as many questions as possible. I would like to start off by introducing our moderator for the event, Dr. David Lebowitz. Dr. David Lebowitz is a practicing internal medicine physician and co-director of the Center for Medical Education in Data Science and Digital Health within the Institute for Augmented Intelligence in Medicine for the Feinberg School of Medicine at Northwestern University. He is board certified in clinical informatics, and his background includes a degree in electrical engineering. He has led numerous information technology projects for use in clinical practice and research. Operational leadership experience includes former roles as Chief Medical Informatics Officer at Northwestern Medical Faculty Foundation and Chief Medical Information Officer at University of Chicago Medicine. Our speaker for the event today is our very own MD alumni from class of 1992, who is also celebrating his 25th reunion with us this year, Dr. David Rowe. Um, Welcome. Dr. David C. Rowe is a Global Chief Medical Officer and VP of Healthcare for Microsoft. He is adjunct professor at Stanford University, holds 6 U.S. technology patents that enable authoring, mapping, and integration of clinical decision support into electronic health records, and has been recognized as one of the 50 most influential persons in healthcare by Modern Healthcare. Dr. Rowe received his Bachelor's of Science degrees in Computer Science and Cellular Molecular Biology from University of Michigan. He received his MD degree from Northwestern University and completed internal medicine residency at Cedars-Sinai Medical Center. He completed fellowships in health services research at Cedars-Sinai and infectious disease at the University of California, Los Angeles. He has served as CMO and VP for Samsung, SVP and CMO at Zinc Health Incorporated, clinician researcher at the VA Greater Los Angeles Healthcare System and RAND, and associate clinical professor of medicine at UCLA. Dr. Rowe has also served on the National Quality Forum's Executive Committee for Consensus Standards and Approval, chaired the Consumer Technology Association Health Technology Board, and sits on the governing committee for National Evaluation System for Health Technology Coordinating Center, the medical device advisory group for the FDA, CMS, and NIH. Without further ado, Dr. David Rowe.
Wow, what introduction. Thank you so much. Such a pleasure to be here. I can recall when I graduated from medical school, there was such excitement and anticipation of what that next chapter in my career would be. And I was very fortunate to have had the opportunity to have been exposed to several technologies and approaches that have given me insight as to what could lay ahead. But really, I could never have predicted it. And much of what we were looking at was just really an opportunity for us to find ways to improve care. Much of the work that I did during my fellowships in both health services research as well as in infectious disease was around looking at ways that clinical decision support, or actually the right information at the right time, could be used to improve health outcomes. What I found, though, was that if you couldn't apply it in a scalable way, something that could be applied consistently, you didn't really have an approach that could be sustainable. And oftentimes in my studies, I found that we could get results, so it actually got publications, which was fantastic, but it was never something that was sustainable from a system perspective. So I felt like we needed to look at technology as an approach. And that idea soon became a company, which then was acquired by Cerner. And next thing I knew, I was implementing EHRs across the board. Now, one of the things that was very interesting about that time was something was happening that was very external to my career that was going to completely change the trajectory of not only my career, but for many others, the healthcare industry. And that was meaningful use, or what some of us have now referred to as the High-Tech Act. And that has revolutionized in many ways the way that we think of how healthcare records can be utilized. But it also has given us the opportunity to understand that there are additional trends that will continue to change and transform the healthcare landscape. So what I wanted to do is I wanted to talk to you about some of those trends that we are seeing that will likely have a direct impact on the practice that each of us does, whether it's in private practice, clinical practice, or in research. And so what I want to do is focus on three major trends that give us an opportunity to understand how this could be applied in our practices, but more importantly, how this will change the healthcare landscape. Health equity is something that we hear all the time. It really relates to the disparities of care that we see within certain subgroups. And oftentimes socioeconomic factors are at the underlying cause of that. But we also are trying to find ways to address those through the health system. I'm going to share with you some of the insights that we've gathered working at Microsoft and through other partnerships around how these health equity issues can be applied and how technology can help us scale. Additionally, consumerism. This is an area where many folks have talked about the transition from patient-centric to consumer-centric care. And what that really means is giving the better experience, the experience that people expect and demand from the healthcare system that oftentimes hasn't been there, allowing people to have the right information at the right time, make smarter decisions, and be able to be empowered with health information. And the third is something that we've heard a lot about during the pandemic, which is virtual care. The CEO of Microsoft, Satya Nadella, has said that we've seen about 2 years of digital acceleration in 2 months, and that's across the board. Now, a large part of that has been in the form of telehealth, but what we've also seen is an opportunity where artificial intelligence and machine learning is being incorporated into virtual health. So these three trends, health equity, consumerism, virtual care, combined with AI and ML, are the topics that I'll cover today, and we'll start with the health equity piece. So one of the things I wanted to talk about with regards to health equity is just the way that care is delivered today. A large part of it is based on patients coming into a facility, it could be a hospital, it could be a clinic, but they have a need that they've identified and they've got the transportation, the mode to be able to get there. And we then expect them to continue to receive the follow-up based on them following certain instructions. Now that's been sort of our tried and true methodology. Now what happens is this works for several individuals, but unfortunately not for all individuals. And we've seen this where individuals that have issues that relate to what we sometimes refer to as social determinants of health or social influences of health. We're talking about food insecurity, housing, job, the environment that they live in. These are all factors that impact their ability to receive continued care. And if we don't address those, it's unlikely that we can expect them to get better care. Mental health, behavioral health issues, substance abuse, all of these are factors that also play. And so we have to think about changing the model. So rather than the individual coming to the facility to receiving care, we need to start thinking about how care can be delivered to those individuals in the neighborhoods, in the areas that they are at, but also addressing those social determinants. Now, this is something that became very apparent that we needed to address this urgently during the pandemic. And one of the things that happened during the pandemic was, because of my background as an infectious disease doc and Microsoft's role as a global technology provider for governments and healthcare organizations across not only the nation, but also other countries, I found that there was an opportunity to apply technologies to help us deliver on vaccinations in areas that weren't reached by healthcare technologies traditionally. So the EHRs, we know certainly are a great source, perhaps maybe going into clinics as well. But what wasn't necessarily possible was mass vaccination sites or pop-up clinics. And so in that ability for us to address that, we started working on technologies that were cloud-based and would allow us to be able to stand up those services. And we thought by making it more accessible that we could potentially address the issue around vaccine inequities. And it helped. But again, back to the core issue, we found that there were a significant number of individuals who were not getting vaccinated. And the reason was not because of access to care, but because of trust, and largely because there wasn't a conversation with individuals who had that long-standing trusted relationship with them, where they could talk to them about their concerns, their fears. And many of the fears were things that went well beyond the pandemic. We were talking about historical concerns of mistrust of the government, mistrust of the healthcare system. And these are things that were not something that we could address just simply by providing an advertisement or showing somebody getting vaccinated. And so what we realized is that the first step was we need to have individuals in the communities empowered with the right information at the right time to be able to make those conversations meaningful for the individuals. Oftentimes they're related to concerns about immigration. And then once we had those conversations and people started recognizing that this is something that they could do, and we're talking not just about healthcare providers, we're talking about leaders, religious leaders, community leaders. We're talking about individuals that work in the neighborhood barbershop or the beauticians. And we started this process in Washington, and we found tremendous success applying this with the Latinx community. We then started moving towards California, working with migrant farm workers. And that was an incredible learning experience, identifying some of those concerns, and then started working in coordination with sites in the Southeast, in particular in Georgia and then Mississippi. And it was a coalition of partners all working together with public health, a real public-private partnership. And one of the other opportunities that we saw was that we could deliver more than just simply healthcare or vaccinations to this, but we could expand that to include things such as immunizations that were missed during the pandemic. Oftentimes, many of these individuals at the time were thinking about getting their kids back to school. So childhood immunizations and adult immunizations, and then blood pressure screening and heart and cancer screenings, and then connecting them with insurance. Many of them were eligible, they didn't even realize it. And the next step was then connecting them to a healthcare provider. And so all of this ended up becoming something that what we realized was very much led by individuals and communities, but the data itself had to be brought from the communities to immunization state registries, to EHRs. And that's where we found that technology was helping to support this, but not necessarily the leading actor in this story. And we've now started to recognize that if you empower consumers with that right information at the right time, you can enable them to be able to make smarter decisions and be able to have better health outcomes. Now, what we oftentimes think of when we think of technology and consumerism is we think about smartwatches or smartphones or a variety of different wearables that people use. It's giving us information about our bodies, and it's helping us to understand what we need to do to perhaps improve our athletic performance or our fitness or our sleep. Now that is an important part, but the reality is we found that many times we have to go beyond simply providing biometrics, and it gets to the core of giving consumers access to their health information. And if we think more broadly about what that means, it means about having consumers be able to have portable health records brought onto the device or technology of their choice and be able to enable them to be able to port that over to other clinicians. We've seen this all the times when patients come into an ER, they need that information. We rely on HIEs, but imagine a patient being their own HIE. Well, this during the pandemic has actually become an opportunity for us to be able to leverage the standards that we use for interoperability, in particular, fast healthcare interoperability resources, or FHIR, and apply the Smart on FHIR technologies to enable consumers to be able to have access to their medical record. Now, in this case, it's the vaccination as well as the test results. And through that adoption of smart health cards, consumers now can actually have their health record, part of it. And as we continue down this path, this is something that consumers can potentially get their entire medical record. Now, what's exciting about this effort is this has been supported by healthcare organizations across the country, by the EHRs, by many countries and states. So this has now become a major global effort. And the more that we can get interoperability and consumers to be engaged with their health records, the more likely we'll be able to achieve some of the great benefits that I'm going to share with you shortly. And one of the things that we recognized during the pandemic is that we needed to have more touch points with the patient. And oftentimes these touch points had to be virtual. A lot of times the virtual visits ended up becoming video consults. But what we also saw was that data was central to a large part of this. If we understood individuals and where they were on their journey, we could better help navigate them. And what you see in front of us here is multiple different use cases of how once we have data secured and managed appropriately, we can create mechanisms to provide personalized care, virtual health, allow us to be able to then pull that information, then analyze it. And so if we think about this, I'll call it a flywheel, with each one of these is divided into 3 sections. The upper left is about pulling information in, the data ingest. And then the lower part being around analysis of it. So the analytics and the opportunity for us to apply AI and ML. But it has to be acted upon. And so if we go to the upper right-hand part, it's about care collaboration and care coordination. And so it's really those 3 things that we talk about when we talk about data management. It's about ingest, analysis, and care coordination and collaboration. And more specifically, if you think about the data inputs, EHR is a critical part. So let's start on the left-hand side. But we also have seen tremendous opportunities with images, with genomics, proteomics, and the internal workings that we have. Third-party data, social determinants or social influence of health. Some people say that, and it's been shown, that your zip code is the most significant indicator of your health of any other type of piece of information. Internet of medical things. And the reason why I call it Internet of medical things as opposed to Internet of Things or IoT is because there's patient identifiers associated with that health information from your wearable or from other devices. And as we think about how all that information gets ingested and brought, it has to be brought into a platform where you can apply AI and ML at scale and then coordinate it across a series of different types of technologies that expand beyond the healthcare EHR, but also include the workflow for the clinicians and other care workers. And so in this process, we've now seen that we can start engaging consumers with these tools right where they're at. So again, back to the pandemic, one of the great examples that we saw was when consumers had questions about, do I need to see a doctor because I've potentially been exposed to COVID, or I have a slight fever or a cough, or maybe I'm just worried. And what we saw, because information wasn't readily available, it was on the websites, it was on the CDC websites, but people didn't take that information and individualize it for themselves. It was very difficult for people to read that, to some degree, complicated jargon and understand, well, what does that mean for me? Do I have to see the doctor? And because of those questions, they ended up coming into urgent care, ERs, and sitting next to people who actually did have COVID. And so one of the first emergencies that needed to be addressed during the pandemic was information to populations, and chatbots ended up becoming a critical part of that. Now, what a chatbot is more than just simply a tool that answers questions. There's an AI engine in the back that is allowing us to be able to take that conversation and apply an algorithm on it that allows you to get an individualized recommendation. So the CDC started taking the AI-based chatbots and customized their own chatbot, which then was surfaced up through multiple different mechanisms. It's surfaced up on mobile phones, as apps, it's surfaced up in websites, and other hospitals and health systems and countries throughout the world. To date, over 1 billion messages specific for COVID have been delivered, individualized recommendations to help people understand, do I stay at home or do I come in for a visit? But typically, it was about keeping people at home and away from others who potentially may have the infection. Now, that is one great example of how AI-based chatbot technology can be used by consumers. But another extraordinary opportunity is to start thinking about how we can provide the right information at the right time for everyone on the healthcare team. So, we've oftentimes thought that as healthcare providers, we're overloaded with a lot of tasks, but we have a whole team around us that could help us. Everyone from nurses to pharmacists, but of course, there's other folks in the front lines. There's the call center agent, there's the receptionist, there's the case manager. How can they be part of this process? Well, let's just start with the typical example. Let's imagine if I had, a question about COVID and I called and I said, I'd like to schedule an appointment. I'm concerned about this. Well, typically what the receptionist does is they schedule an appointment, or they look in the appointment and they find a slot. Well, that could be a missed opportunity. Let's imagine I'm one of those individuals who's missed my last 4 appointments. Really what should be happening is there should be an algorithm that's running in the background that identifies that I've missed my last 4, and the call center agent or the receptionist should be prompted with a recommendation to say, hey, we know that you've missed your last 4 appointments. And in that scenario, did you know that we actually have services to take you, if you need transportation? Oh, did you realize that this is a perfect opportunity for you to take advantage of the virtual care services? You've never done that before? We can set that up right now. These are the types of things that can be done in advance of the visit, before they actually even came to see the doctor or the healthcare provider. So, what we're starting to see is that we can apply clinical decision support across the care continuum for multiple different individuals, consumers, as well as the extended care providers. Now we're getting to this issue of the topic of virtual care. Virtual care has been extraordinarily important during the pandemic and will continue to be important beyond the pandemic. But what we're doing is we're scraping the surface of what's possible. What we've seen with virtual care is that it oftentimes falls to the basically a video visit is really what it is. It's a video visit between a doctor and a patient. Now, sometimes you'll have other clinicians as well, but what we're finding is that virtual care is so much more than just a video visit. If we think about how the data can be surfaced up and then how AI can be applied on top of it, we have an opportunity to be able to transform the way that we interact with patients. So let's share a few examples. I'm going to give you 3 examples of how virtual care combined with AI and ML can transform the user experience. So this first one is about the use of artificial intelligence in a clinical encounter where a patient and a doctor are just simply talking. So let's watch this video.
You don't become a doctor to bill. You become a doctor to take care of patients. You become a doctor to serve humanity. Ambient intelligence allows for the patient and doctor to be a patient and a doctor, like it used to be.
There's a certain business requirement for a structured note and careful documentation, precise diagnoses, and carefully backed up coding for the business practice of medicine. But ultimately, it's about the patient's story.
If you look at the promise of meaningful use and all the reasons we got into a digital health record, it really was to take better care of the patient. Unfortunately, sometimes we've done that through a barrier, meaning we added a keyboard, we added a computer. And I think that's a key part of why physicians are frustrated.
And I mean, you notice as a patient, you notice that your physician is typing and talking and, yeah, okay, yeah.
Now we can go into the background and just capture all the information you needed, but also maybe more importantly, capture something that was missed. That missed was the patient's story.
There's a device on the wall and it's listening to your conversation and it's able to discriminate between a patient and a physician and a family member and is able to generate a progress note and a patient encounter based on your conversation.
What it has enabled is that I can pay attention to what you are saying, because it is very important for me to have the empathy and you to feel as a patient that you are telling somebody who actually cares about you.
Hey, Dragon, start my standard order set for arthritis pain.
The idea of a computer that can listen like in Star Trek and just hear what's going on and make sense of it and slip into the background and listen, but only interject when necessary, that was for a long time a fantasy.
I would say before, in a typical week, I would probably spend 6 to 8 hours documenting, just simply dictating and signing notes. I bet that my time has been cut into half, if not thirds, because of nuance now.
It takes the hands-on time that the provider has to spend with the computer and puts that time back with the patient.
It really takes a lot of that manual work out of the patient encounter and just allows it to happen kind of naturally.
Ambient puts a listening device in the room quietly, securely, privately, and allows the 2 people in the room to really have a very intimate discussion on very private things. Knowing that the necessary recording of that for the business of medicine and healthcare can go on in the background, but letting that personal connection continue. And that's the reason I think almost all of us went into healthcare. It's to be able to be there for people, to express caring, to express empathy, and to connect as human beings.
So what's happening is the conversation between the patient and the clinician is being captured first through voice to text, but it's also recognizing who's speaking. Now that voice to text, then the AI on top of it understands the context of what's actually being spoken and maps on the back end to the different terminologies. From there, it allows, because it's all been mapped and understood by the computer, it can be organized into the clinical progress note, which then the individual clinician can review and then push a button and integrate into the medical record. So this is a technology that can also be used in a virtual care setting. So imagine having a virtual care visit. You can do the exact same technology and have the same type of impact. So extraordinary opportunity for us to transform the user experience. Now, another example, and this falls into the category of what we call natural language processing, because it's about the use of your language, but converting it into formats that we can understand. We can also apply it, so that was voice, we can apply it on text. And now this use case that I'm going to share with you is about how looking at the medical literature and searching it, all of that, providing that information real time allows us to be able to make smarter decisions. So let's take a look at this video here.
We're all touched by cancer in one way or another. Every cancer is different. Tumors can have hundreds and thousands of cell mutations. How do we find that one change that we can target and treat that cancer?
There's millions of scientific articles covering specific mutations and combinations with drugs.
We can't possibly keep up with all that literature.
The clinical knowledge base is an innovative technology where all those variants, mutations that exist in cancer are being curated as they're discovered by researchers around the world.
That's where our collaboration comes in with Microsoft AI to help us triage the literature. Machine-assisted human curation can assist going through all of those publications and saying, this is one, so that the team can use their scientific expertise to interpret them.
It's a life or death situation. It's also a question of how you accelerate certain discoveries and bring them into clinical practice.
We have a stage 4 esophageal cancer patient who's 60 years old.
We can more accurately predict patient responses to a combination of targeted therapies, immunotherapies, and even drug resistance. It is that funnel to be able to get to the right mutation with the right treatments associated.
With Microsoft AI, oncologists will be able to improve patient outcomes.
Every morning I wake up to fight cancer. Through the collaboration with the Jackson Laboratory and Microsoft AI, we can know that we haven't missed anything. And it's just been wonderful.
Yeah, so again, in this example, the natural language processing, in particular, the text analytics, is being applied on the clinical literature to help identify the studies so that the clinician can identify what is the most appropriate treatment. We can imagine the same type of technology being applied on progress notes or other types of unstructured forms that allow us to be able to rapidly accelerate the review of those and basically improve the efficiency of our overall processes. So those were two examples of natural language processing. I want to talk now about another form of artificial intelligence that, when presented through a visual lens, allows us to be able to rethink about how we can not only provide better care, but also think about how we can educate and train. So I can give you 3 examples of how mixed reality in the form of holographic medicine allows us to be able to have improved experiences for the patient, enable greater collaboration and with other clinicians, and then also improve the educational process for young trainees, but also potentially other faculty that may be across the globe. So let's talk first about the holographic medicine. And this is an example from one of our partners, Apocular, where they've been working to pull images from CT scans and MRIs and create 3-dimensional, very accurate depictions of what the anatomy is that will help them in pre-surgical as well as post-surgical discussions. So let's take a look at this here.
Medicine is in the midst of digital change. Mixed reality and artificial intelligence are already improving patient care today. Virtual Surgery Intelligence, or VSI, is doing just that. With this software solution, MRI, CT, and other medical scans are displayed in 3D in Microsoft HoloLens 2 mixed reality glasses. This gives the patient a deeper understanding of the results, surgical procedures, and treatment methods. Before surgery, the doctor uploads the CT and MRI data onto HoloLens 2. The VSI recognizes the patient through anatomical landmarks and positions the stored image on the surgical site with millimeter precision. During the after-surgery round, the patient's data is quickly retrieved and displayed using VSI and HoloLens 2. At a glance and without a computer, the doctor can concentrate fully on the patient, answer questions, and discuss follow-up medical care. Being able to easily dictate a report, take photos, and retrieve archived images saves valuable time, facilitates everyday life in the hospital, and provides quality assurance. That will also make other processes in the hospital more efficient. VSI and Microsoft HoloLens 2 define a new medical standard.
So I think the interesting thing is that the device itself allows you to be able to visualize it, but on the back end, the images and the 3D is actually being done through AI in the cloud. Now, let me provide another example of how this HoloLens can be used in a clinical setting. And this time, we're going to combine the HoloLens capabilities with something called Microsoft Dynamics 365 Remote Assist, which essentially allows us to be able to have virtual collaboration with multiple different individuals across multiple different venues. So this is just an example of some of the great work that some of our partners across the pond at the NHS are doing, and it gives you an idea of how this can be used in a clinical setting.
The concern was that we were going to have mass casualties with thousands of people dying, and that the hospital was going to be overrun. And it was immediately obvious that we were not protected, we didn't have enough PPE, and so there was a lot of fear that actually we were all going to get really sick. And then in the second week of March, that's exactly what happened. You know, we lost a third of our team in a week. I was sat there at the beginning of the COVID pandemic and I counted 29 people in a close proximity in a single trauma call. And I was thinking, well, if this is how we're going to run the next few weeks, a lot of people are going to get sick and we have to change this really dramatically. The simple concept was, look, we're going to create completely virtual ward rounds. Rather than sending 4 people, we're going to send 1 doctor in. We very quickly started working with the headsets to identify some use cases. So when you place the headset on your head, what the user will see is a virtual screen or a mixed reality screen, which they can position into any real space in the room that they're standing in. And on that screen at the moment will be the face of one of their colleagues who will be interacting with that user through a webcam based on a desktop. We can call other experts that we might want to call into that clinical scenario. And we can also pull up images and content. So we can look at electronic healthcare record data or x-rays or images. And what it means is that you have all the information, all the specialist care that you need at the patient's bedside, there and then. And it's all in one headset. When this crisis hit, it became apparent that the NHS had to work in a different way, and through really high-level strategic kind of digital infrastructure projects, Teams was just nationally adopted by the NHS. Teams really is now, I would say, an essential tool. We could not run our organisation pretty much without it. The fact that their staff are safe, their ward rounds are really efficient, and that they can communicate more effectively with their staff. COVID-19 will change everything forever in terms of the way we work and how we work. In terms of mixed reality, HoloLens 2 really is the only viable product that we have in the space. And I can see a point where these sorts of tools will be the norm, where you will go on a ward round, or you will go into a clinic, or you will go into an environment that might be high risk, that might be challenging, or where you might need specific capabilities of these sorts of technologies, and it will be there, and you'll just use it, and it won't be a novelty. What I'm absolutely convinced of is that we are just at the very beginning of a very long and exciting journey. And I think what's been very important about COVID is actually it's just given us a real shot in the arm and a huge step change in our perception of these technologies and what value they might bring. The concern was...
So the third use case with regards to the mixed reality is around education. And this is an area where we have seen, in particular, medical education. It provides a unique opportunity for us to be able to take a look at 3 dimensions, certainly doing it virtually, but you can create new case scenarios around this. And this has been deployed in several medical schools across the country and even the globe. But the one use case that I'd like to highlight is the work that's being done at Case Western Reserve, where they found in their analysis that the individual students actually had higher retention rates with 40% less class time. And certainly as a former Northwestern medical student, I would appreciate that less class time. We're now starting to see all of this connected together. And what I want to share with you is sort of the broader vision of where this is going. These aren't just about headsets. They're about the data all coming together on a platform, which we refer to as mesh, which the AI is placed on top of it. In fact, any type of device can integrate onto this, a VR headset, a mixed reality, a PC, mobile phones. Apps can be built on top of it, but it creates a brand new virtual environment that allows for collaboration. So when we think about that next generation of virtual care, it really is the metaverse, so to speak. And this is the Microsoft Mesh is our platform that supports that. Want to talk about, when we talk about virtual care, you can't go without talking about remote patient monitoring. Now, remote patient monitoring is one that has sort of many positives, but also some negatives as well. One of the great positives is that we have so many sensors today that can detect multiple different types of parameters, such as everything from, of course, weight and temperature, but we've got things that go well beyond, almost things that are hospital-based type of measures that we can now record real time. And typically what happens is the way that it's presented back to the clinician is in the form of a dashboard. And that dashboard is for each biometric, you can have a threshold for upper and lower. Now, this is getting into some of the negatives, because the reality is all that information is just too much for individuals to be able to synthesize. And a lot of times it really doesn't change the clinical practice. And so what we really do need is we need to kind of think of a new paradigm for remote patient monitoring. And this is one where this is a screenshot from one of my favorite movies called Moneyball. And for those that remember this movie, what they were trying to figure out is, can you use data analytics and all the different metrics that they're capturing, synthesize it all down to one number and determine who are the players that can lead to the best chances of winning a ball game. Well, in this scenario, what we're doing is in healthcare, something very similar to what we've done in the past. I'm an infectious disease doc. A lot of my research early in my career was around community-acquired pneumonia. Some of you may be familiar with this. This is the Pneumonia Severity Index, or the PORT score. Now, it turns out that what we did is, to get this score, there were many studies that demonstrated that each one of these had, through multivariate analysis, higher relative risks. And then they put those together in a prediction score, and they validated against large cohorts to demonstrate that when you put these numbers together and you get a score of a certain number, these individuals have higher or lower risk for 30-day mortality. Now, that took years to be able to develop, and it only works for when a person gets admitted to the hospital. We now have the ability to be able to do that real time, because we're capturing data on patients at a very discrete level. We can organize that information so we can look for patients like me across entire populations. The larger our cohort, the larger that we can then draw correlations with whether or not you are heading in the right direction, the wrong direction, or just stay the course. That's the type of information that clinicians need. And that's where AI and advanced analytics are heading. Helps us with population health management, but also provides a more personalized recommendation. So I've shared with you 3 major trends that are going on today: health equity, consumerism, virtual care. With each one of them, there's an opportunity for technology to help us scale. We're starting to see with health equity, the role of public-private partnerships and the need for technology to be able to capture secure data and bring this to the necessary data sets. Consumerism, it's about consumers being empowered with health information, and then allowing us to be able to expand that capability to those that can support consumers to make smarter decisions. Sometimes I refer to as clinical decision support for everyone, including the consumer as well as extended care providers. And then with virtual care, let's not think about it just in the context of simply having a video visit, but now let's think about it in terms of how AI can enhance that experience through natural language processing with voice and text, allowing us to be able to use the visual capabilities of mixed reality and the metaverse, and allowing us to understand how remote patient monitoring can be enhanced with predictive analytics that allow us to be able to become much more useful for the clinical practice. Thank you very much. And I guess at this point, I will pass it back to you, David.
Thank you so much, David, for a wonderful presentation, an overview of so many exciting topics. And I'm sure the audience was thrilled to see some of the kind of hybrid virtual reality that you demonstrated, and thinking about how that really might help make rounds more efficient. With a variety of these exciting topics that you mentioned, just to jump into some of the questions, what are some of the key obstacles to adoption of a variety of these technologies? We have kind of the AI, the virtual reality, a few other things you mentioned. What are some of the key obstacles that you see that are preventing us from being there now? There are some examples where kind of that trend of projected course during a hospital stay has been in the literature for many years. There have been products that have been offering for many years, but we still don't have it in place. So what do you see are some of the obstacles, and how might we transcend those obstacles?
It's a great question. And we see it all the time where there are so many great point solutions that can solve individual problems. But with every point solution that you add on top of the tech stack, it's harder for any organization to be able to manage that. And so what we need is we need to be able to make sure that they all work well together. The problem is they don't always work well together. They're not necessarily interoperable, and the data is siloed, and it's difficult for us to be able to bring all that data into something that is far more useful. This is the reason why we start talking about a new platform, a data lake, that is oftentimes required. I'm going to give you an example. During the pandemic, we were asked when things weren't going well by the World Health Organization to help support them in their effort to build a single data hub for across the entire globe to be able to help better manage this. And the recognition was that they needed to build first a data lake, create workspaces within the data lake, have country-specific portals, have a consumer interface that allows them to report out. All of that needed to be done real time. And so we started that project with the World Health Organization. I was one of the co-PIs on that, working with Accenture, actually Avanade. And recently we presented that at the G7 to share some of the great learnings that we've had during this. And while we're still on a journey, because this is something that we're just starting to build infrastructure, we're starting to realize that organizations, whether they be it the World Health Organization or Northwestern or any organization, has to start thinking about their infrastructure. Once they have the infrastructure in place, they can build off of that. And that's where a lot of the technologies that Microsoft has been focusing on. I showed you some great point solutions, but the reality is it's the infrastructure that supports this that allows us to be able to do things at scale.
Thanks so much, David. And just to follow up on that, and then I'll get to some of the questions also from the audience. Early on in your presentation, you talked a little bit about the trust that was often missing in terms of the communication with the community and vaccination. When one thinks about kind of a more massive infrastructure, especially with vendors being involved, what are your thoughts about helping establish trust? It sounds like one example is partnering with the World Health Organization. Any other thoughts on that about how trust to aggregate this information and then bring it to life, how we might achieve that?
Yeah, it's a great question. And this is one that I think we're starting to realize that we have to be proactive in our efforts, that we have to be proactive in terms of what we say and do about data security, data privacy, data transparency. Because if that's not made apparent up front, there won't be trust. And that has been one of the biggest issues when you think about how trust was broken, because there wasn't a clear expectation defined and lived in and fulfilled. So it starts with understanding what is the organization planning to do with that data. At Microsoft, we've taken the position where we said, you know what, this is our clients and the patient's data. We have no interest in monetizing it. We have no interest in doing anything apart from securing it and making sure that we can build technology on top of it to make it useful. And I think that's a position that's allowed us to become sort of the trusted partner for governments and for the WHO and for health hospitals and payers and across the industry. So in large part, that has become a cornerstone for what we have found to be highly important and valuable. But I think then the next piece is empowering the individuals who have that trusted relationship to be able to do more. And in many cases, they're healthcare providers that are working in the field, as well as people that are community health workers, social workers, case managers, and other folks. And we're now realizing that we all need to work better together. And that's been probably one of the big lessons during the pandemic, that we have a fragmented system. Public health sits in one silo, healthcare sits in another. You've got other groups that are trying to do work, but we're not communicating. So interoperability becomes a big part of how we enable that. And then, these partnerships.
Great, thanks so much. Shifting gears a little bit, and this is a little bit of a meta question, and partly for the students and also the instructors, would be, how does digital health differ from Mhealth or remote home monitoring?
It's a great question, because I think these terms are so commonly used that we oftentimes get them very much mixed up. So when we think of digital health, think of that in terms of the broader way of anything that is digital that allows us to be able to be applied in a healthcare setting. So within there, you will have remote patient monitoring. You'll have Mhealth, which is mobile health specifically. So mobile devices, are a part of that. But each one of these is a subset. So connected health is oftentimes another term that we hear a lot of. That's connecting an individual, patient to a healthcare provider. Telehealth, another part of that, or telemedicine. Telehealth being the broader term, telemedicine being specifically for the clinician and the patient. So there's a lot of overlap between all of these. Sometimes we use them pretty much interchangeably, but I think digital health is probably the broader term that allows us to be able to talk about multiple different technologies.
Great, thanks. And our clinical informatics fellow, Gigi Dawood, has a question on getting into a specific example with a little bit of this. So given the deluge of patient-driven device data, how do providers drill down to the most important pieces versus the noise from these devices? Insulin pump data generates 25 pages with no way to upload into the health record, assuming one actually wanted to. My parentheses added, adding more devices is daunting. So your thoughts on that?
She's absolutely right. What we have to do is we have to stop with the adding of more data and more devices and start thinking about what can we do with the information that we have. This is where AI and analytics have to be applied on top of this. This gets back to one of the slides I showed earlier. We have to start synthesizing that information into actionable things that can be used. And it doesn't all have to go to the physician also. Let's think about enabling the entire care team to be able to take advantage of the fact that they may be the ones, not necessarily saying, hey, there's something wrong, but a phone call to make sure that the person's doing okay. Making sure that their appointment isn't scheduled for a week later, but perhaps maybe a couple days later. I mean, these are the types of things that can make a difference. A lot of times, when we think of it, it has to go to the physician has to review all of that. That's not necessarily true. In fact, that is not true. A lot of this can be done in terms of appropriate triage.
Oh, that's great. Thanks. We have so many great questions. I'm not going to be able to, we're going to run out of time, which is fine, but we'll keep working to the end.
Okay.
Here's an interesting question. How do vendors such as Microsoft envision health information data exchange? And when will patients be empowered to enable precision medicine data analysis, leveraging data exchange? So the patient empowerment side of it, and where do we stand on that data movement?
Yes, so interoperability, that's the key buzzword. What that really means is just making sure that the data can be moved from different system and understood. Now that is something that benefits everyone. Healthcare providers in particular allow us to be able to think about how we can exchange data with other colleagues so that it allows us to potentially provide a more consistent care. but of course the patient. And if we think about the patient and the consumer being able to gain access to their medical record and be able to have that portable and be able to allow that information to be understood by anyone across the country or the globe, that's the value of consumer empowered patient medical records. And that's where we would like to see this movement of interoperability head towards. Right now, it's still very much focused on, so we'll call it the HIE, the patient, the providers and the payers, but eventually and the populations now, but we're eventually going to get to the point where consumers will find value in it, and there'll be an opportunity for them to be empowered with that information.
Okay, we've had a few questions about career opportunities and other career tracks for physicians. So in that theme for a moment, do you have suggestions for mid-career physicians who might hope to transition some or all of their full-time effort to digital health? For example, low-hanging fruit, where to start and the like?
Yeah, so David, I'd actually like to turn the tables and ask you that question, because I'll answer it, of course. But David, since you and I have had similar paths in the sense that we are now in a space that involves health informatics and technology, I'd love to get your take first on that.
Yeah, no, absolutely. So I think there are many opportunities. Part of it is to think if one has a specific idea already. David kind of covered a variety of topic areas, and depending on one's interest, one can begin to explore some of those opportunities. If one, for example, were a radiologist and working together with some of the companies in this space, one can explore how to improve some of the products, and then that makes it a little bit easier of a transition. If one wants to start completely in a different direction using information technology, there are a variety of courses and opportunities where one can learn more. A key reference to mention for everyone listening is the American Medical Informatics Association, known by its acronym AMIA, AMIA.org. There's a variety of educational opportunities listed through the AMIA website, attending the various AMIA conference meetings that exist, and seeing, especially from an academic home perspective, where you could still practice and explore opportunities. That's one area to look into. Additionally, if you're at Northwestern, feel free to reach out to me. If you're still at Northwestern, even if you're not, that's fine to reach out to me, and I can offer some more specific suggestions on that point. So just to open that up, feel free to reach out to me, and I can help target that question a little bit more specifically. But go ahead, David.
First of all, I am so proud of the work that David, you and colleagues are doing at Northwestern to bring informatics and healthcare technology into the curriculum. That is exactly what we need to start doing so that individuals can be given the opportunity to see that how technology can be applied in a clinical setting, and then understand how they can build a career around that. Now, for those that are sort of midstream or in mid-flight, the path that you described is the exact right one, the informatics piece, because that allows you to be able to understand how the data can be integrated within the existing EHR and other systems outside of that. So that's where you learn about interoperability and all the other key terms that I may have thrown around pretty freely here. But that's a great starting point. Another area that I think oftentimes gets overlooked, but is a great opportunity is health services research. This is something that for me, I didn't realize that's actually what got me into this whole area. I started looking across populations and started seeing wide variations in care. And a lot of that was unwarranted variation. And then I started realizing that if you provide the right information at the right time, you can transform that. And technology ended up becoming the vehicle to deliver that. And that was I'd say, essential part of my understanding of how technology could be applied. And it ends up being one of the cornerstones of how technology today needs to be applied. A lot of times you see people, especially in Silicon Valley and other parts, where they're building technology that looks really cool, but it doesn't have that proven outcome. It doesn't show that it's reduced any bad outcomes. And a lot of times people assume that that's just going to be something that clinicians will assume that will happen, but you have to have the clinical studies that support it. So you have to know how to be able to take that technology and measure it and demonstrate the value, and that will then eventually lead to greater adoption and things like that. So it really is both. You need the understanding of the technology, but also how it can be applied in a healthcare setting.
Yeah, and that's not easy. Obtaining the funding, conducting the studies over time. This takes time and discipline. For the purpose of kind of transitioning from a career, one other thing I'll just mention to learn a little bit more, there's a variety of programs that exist that Northwestern has too. We have our master's in health informatics. We have a master's in quality and patient safety. Some of these programs I've been involved with and continue to work with. And with them, one could take courses. One could also attend various seminars that are offered as well. So just to get kind of a little bit of an early study, an early exposure to decide, is this for you? Kind of a follow-up question on this similar theme. David, what problems are you recruiting physicians to solve at a company like Microsoft? And what skills and experiences should one develop in order to work in the space?
Great question. We oftentimes are very interested in clinicians that have problems where they've been looking at perhaps maybe how artificial intelligence could be applied to solve it. Working with folks at Northwestern, about a variety of different things that they've identified. But AI is a tool that anything that requires a human to be able to do, think about applying the technology to do it faster and more efficiently. And so that allows us to be able to improve workflow, improve the overall quality and reliability of those performance. That's an area where oftentimes, technology companies, we know the technology, the inner workings of it. We don't know the use cases. So, pretty much anything that you can think of that's a major pain point in your clinical workflow. We talked about one of them, about documenting the EHR. That's a big pain point. And so that's where AI has been, that's been one of the areas where AI has been focused on. But anything that you think about delays, or you're like, why am I doing this? This is so administrative or so ridiculous. Those are opportunities. And, the more that you can either yourself, if you have training in this space, try to develop those, or better yet, work in collaboration with your healthcare organization, with their resources, and have those folks embarking on this journey with you to solve these problems. We come in and we try to support the organizations as they go and try to solve these big, difficult problems.
Thank you so much, David. This has been a wonderful kind of survey of the field and some neat, exciting things to hopefully stoke further interest at Northwestern. And anyone listening, feel free to reach out to me too for further information about what Northwestern currently offers in digital health and data science and clinical informatics. David, thank you again so much. We hope to keep you involved along the way with our journey for improving healthcare. So thank you so much. And with that, I think we'll sign off. And thanks again so much, but we'll let Sonia give the final goodbye.
Yeah. Thank you, Dr. Rowe, for a fabulous presentation. And thank you again, Dr. Leibowitz, for helping us moderate this webinar. We really appreciate all of you on the call today for taking the time and joining us. Hope you enjoyed it as much as I did. This session has been recorded, and we will be sharing the recording with you in the upcoming days. And if you have any questions about today's event, please feel free to reach out to the Alumni Relations team, and we'd be happy to assist you. I hope you have a lovely evening, and thank you again.
Thanks, everyone.
Thanks.
Bye-bye.
Bye.
Bye-bye.